Hello and welcome to North Country Matters. My name is Donna Seymour. I am your host for this program and a member of the St. Lawrence County branch of the League of Women Voters of New York State, one of the civic partners for our show. My guest today is Jeanette Zoeckler, the Director of Preventive Services at the Occupational Health Clinical Center based in Syracuse at SUNY Upstate Medical. Jeanette has been a guest on the show before to talk about various aspects of occupational disease and prevention. The Syracuse Clinic serves 16 counties, including St. Lawrence County. Jeanette, welcome back to North Country Matters. We are here today to talk about the updated report on occupational disease in New York State, which you co-authored with Michael Lax, the medical director at the OHCC Clinic in Syracuse. Let's start by giving folks a thumbnail sketch of the history of the clinic network and why it is unique in the treatment and prevention of occupational disease. That is often called an epidemic that is largely hidden in sight, as you wrote in the report.
Well, the clinic network is unique in the world, and it was established in 1988 to respond to serious and unmet needs for clinical resources to address, occupational disease. And this is as opposed to occupational injury. We care about that too, falls and trips and slips and explosions and things that cause injuries on the workplace can be fatal and dangerous. But this clinic network was designed to focus on occupational diseases because that was the unmet need. And it was really born out of a bipartisan effort in the New York State legislature to fund this independent, publicly funded network. And so there are 9 clinics across the state of New York, and they're staffed by a multidisciplinary team. The team is really the gem and the key to what makes these clinics so effective and so unique. Each one has an occupational medicine physician, board certified, that is the medical director. And then they also employ, of course, nurses and support staff to run a clinic where we really see workers who have been made ill in the workplace. And then, in addition, we have on staff an industrial hygienist who looks after the science that we know we need to apply to the workplace. It could be anything from chemical exposure to ergonomic problems. They look into the science of the workplace, and as their name denotes, they're hygienists, so they're cleaning up the workplace. They look at the toxicity that workers and try to manage that through their studies, through their advice and recommendations. We also employ social workers to address the psychosocial needs and to help connect our patients with resources that they need when they're going through what is typically a workers' compensation case, and also such a big change in their life, as many people are either in and out of work, or they have to leave work for a while, or they have to leave their current employment for something different. So that's a big tumultuous change. A lot of times there's financial hardship, emotional duress, as people lose their identity even sometimes because they're so used to being what their occupation was before they got sick. So we have a social worker that specializes in knowing how to handle occupational disease cases. And then on staff also, we have outreach and education and research components, public health expertise, so that we can get out into the community and prevent people from ever, needing to come through our doors in the first place. Of those 9 clinics, they're dotted across the state: New York City, Long Island, Albany, Rochester, Buffalo, Syracuse, where I am. I don't think I've forgotten anyone in the Mid-Hudson Valley. There's a couple of them in New York City because it's such a large population. And there's also one clinic that's designated for across the whole state to address agricultural medicine and health issues. So obviously agricultural work is super important in New York State. So we have one clinic addressing that whole question. So these clinics, are unique. We've said that there's only one other clinic similar to it in Canada, and we're serving all workers, and it's an independent place. A lot of times occupational medicine is services can be provided within a corporation or within a company into their workers, but we find that we are able to be very independent. So we are under the auspices of the New York State Department of Health, so their oversight. And then almost each clinic has its own parent institution that it affiliates with. And we here in Syracuse are affiliated with SUNY Upstate Medical University, and they provide also a kind of oversight. But the other clinics, some of them are connected to large healthcare institutions like Bassett, or other academic institutions like the University of Rochester or New York University. So each one has its own affiliation. And this strengthens us because we have the New York State Department of Health oversight and support, and we also have, all of these different institutions that we're connected with. We have those resources to bring to bear to the question of occupational disease.
Oh, wow, thanks. That's a lot of information. So the need for the clinic network grew out of the original report about the actual incidences of occupational disease in the state. And in 1987, the state legislature put in place the framework under which you operate. Let's take a minute, Jeanette, to review what the original report found about hazards in the workplace, just to set the stage for the updated report.
Yeah, so the original report was often thought of as the Bible for these clinics that have been in operation for like 35 years. And, that report found there was, 5,000 to 7,000 workers dying each year from occupational disease, and 35,000 workers they calculated were developing work-related illnesses. They found 10% were employed in these 50 really hazardous industries, and lots of toxic materials were in use extensively throughout the state. So it wasn't unusual in those days, to see legally permissible levels of exposure being exceeded. So there still is really this need to clean up workplaces where we know there are workers exposed to harmful chemicals, harmful work conditions. It was costing, they estimated, about $600 million in 1987, and there was almost nothing to address it in the state. And so with the expense and with the seriousness of it, the clinic network was born.
So before we get into the data in the updated report, let's tell people that you use the same methodology to compare results to date with results then. Explain, Jeanette, why that is so important and how it validates this study.
Well, a lot of our findings really are a replication because we're asking the same questions we've been asking since the 1980s. So we're looking at what epidemiologists call attributable fraction. We want to know what portion of this disease that's happening in our state is attributable to work. How much of it is related to the fact that the person was exposed at work? So those methodologies are tried and true. What's good about our report is that in the intervening decades, we've had better, sometimes anyway, better data available, and even more literature has been developed around each disease. So I was able to expand on some of the mortality, especially, and morbidity findings based on some really good work that has come along. So we did base it on, again, very grounded methods in our field, but at the same time, we're able to expand the definitions a bit and to refine what exactly we're talking about when we define occupational disease. So that's where we came with this.
So we're comparing apples to apples in this report. Really and truly, there is, this is not anything that somebody can look at this report and say, oh, well, it doesn't apply anymore because they use different methodology. You were very careful about that to make sure that you were doing the same thing. So although the clinic network treats occupational disease and it offers really important prevention services, the situation as far as hazards in the workplace in New York State still remains a major public health problem. So let's talk about what your findings were in the new report, please.
So in the new report, when we're looking at, comparing apples to apples, as you say, we're still seeing high levels of preventable exposure to workplace hazards. We're having over 7,000 deaths, so it's a greater percentage of total deaths, 3.3% to maybe the range is between 3.3 and 4.7% of all the deaths are related to work. And so that's an important finding. We're looking at chronic diseases that contribute, that result from workplace exposures. We're looking at annual prevalence, which is just how many people of all the diseases going on, how many people are actually having a work-related problem at 13.2% of New York's workers, or maybe as much as 2 million cases. So that's a significant number of people that are still facing these kinds of problems. We're looking at, occupational cancers, circulatory diseases, musculoskeletal disease, respiratory disease. These are still with us, even though the landscape of work and the types of work have changed a lot over these decades. So we have a move away from as many manufacturing jobs as we used to have, and now moving into the service sector. So the types of work and the types of exposures and the types of diseases have changed over time, and we're able to look at that. And one of the most important changes you'll also note is that women have entered the workforce in droves since those days. So it's a significant difference.
Right. So let's talk a little bit about the extent of hazardous work occupations in this state. What are some of those hazardous occupations that are leading to these exposures?
Well, one thing you find with the proliferation of low-wage work is that these kinds of exposures rear their ugly heads in a wide variety of workplaces, where there's this traditional idea in your head where construction workers do dangerous works and they get exposed to, sharp objects, dusts, all manner of things, or maybe you're thinking of a chemical plant where people get exposed to chemicals and fumes, and those are, of course, are all still there. We have lead exposure in the construction industry. We have chemical exposure in manufacturing plants, and we have silica exposure going on, especially in the construction industry. Asbestos exposure is not because we're still using asbestos as much, but because whenever you disturb it, it's in place, and when construction workers end up disturbing asbestos, they get exposed. And those numbers are there in the report to notice. It's just quite a lot of many exposures, hundreds of thousands of people being exposed. I think now also we do see chemical exposures in hospitals, in schools, in offices. And we're kind of surprised to note that, but these types of exposures do occur in the service occupation. So teachers getting exposed to chemicals, nurses, hospital workers getting exposed to chemicals, people who work in restaurant industry exposed to chemicals. These kinds of things are not unusual at all. And so the new economy with the new types of jobs, we still see chemical exposures, we still see musculoskeletal exposures. So ergonomic hazards, which everyone knows what that is. It's like when our bodies are strained beyond what a body can handle with either repetition or vibration or some kind of small motor, pressing or pushing, whatever the body is being asked to do beyond its capability, then we end up seeing musculoskeletal conditions. And, we think between 1 and 4 million people in the state are being exposed significantly. And that's based on data that we see when people report what their work conditions are like, in, large scale surveys.
You had mentioned earlier as in our conversation about the kind of the invisible hazards, and stress is one of those invisible hazards. And you had said that you have social workers who help workers figure out what stress is doing to their bodies. Let's talk about measuring the costs of stress in the workplace.
Yeah, so psychosocial stress is one of those kinds of stressors that people sometimes don't realize has been very well defined by occupational health researchers. So we're not just talking about a vague sense of when people are stressed out and they feel pressured. I mean, of course, it's work. So what we're talking about when we talk about psychosocial stress is those jobs where there's a very high demand on the person, whether it's too much work basically and too little time to get it done. There's a time pressure on top of the fact there may not be enough support going on in the place. So high demand and low support at the same time as low control. So many jobs, and let's just take a teacher, for example, they don't get a choice about how many kids are in their classrooms. They don't have control over the kinds of curriculum they're using. They don't have control over the processes of COVID protocols in their classrooms. There's so much they don't have control over, and they're asked to do more and more all the time. Bigger class loads, extra meetings, extra professional development requirements, extra coaching, they're asked to do more and more. So there's a high demand, low control. And then we often hear in the news how they're not supported. They don't have the equipment they need. They don't have enough toilet paper. They don't have chalk. They don't have markers. They don't have textbooks. They're not supported. That's just, their buildings aren't, functional. Those are things that denote lack of support for their work. So they're in a situation of a really high psychosocial stress right now. And what we know about those kinds of illnesses that develop is that that's not the kind of illness that, oh, I'm under stress and 5 months later, I'm showing up at the doctor with some result. These are the kinds of chronic diseases that develop later, after 10 years, 15 years. Now we see cardiovascular effects, hypertension, and all the things that sequel from that. We also can see a reduced immune function in people with high stress jobs. So those are effects that cost a lot over time. Many, many people are affected, and work plays some crucial role, or could be playing some crucial role in the number and the amount of stress that the person is facing. So we think it's really important, and it's a part of the service economy where there's a lot of stress to make the customer happy, where there's a lot of people involved. We're not just dealing with machines, but we're dealing with people, and they're often where the stress comes, like angry customers, people on the phone, a lot of high caseloads, serving a lot of people creates stressors for people on the job.
Yeah, I think listening to some news reports back in December about workers who are in warehouse jobs. And there's this constant pressure to fill orders, get them boxed up, get them out. And, those are not great working conditions to begin with. And those folks are under a tremendous time pressure because of the holidays. Everything has to be filled yesterday. So you can see that, and the working conditions are in some cases abysmal in terms of
What's
not being
really
safe.
difficult too about those jobs, they're working unsafe many times, but also we're just starting to begin to study in earnest, what does it mean to be tracked all the time? As though you're not trusted, you've got to be, your every movement is tracked, your every click on the screen. Call center people report this also. They're in a call center and their bathroom breaks are timed. They're, every moment they're on the computer, how many calls they make, who they talk to, exactly. Their job is monitored to a very high degree. We would call that micromanagement, and that creates its own kind of stress. I mean, some of the other stressors workers face that affect their health are irregular work schedules, dealing with aggressive people. Like if you're working in a ward on a psychological unit and you're a nurse and you have to deal with some patients who aren't themselves or not well and they're physically aggressive. Alzheimer's patients, like sometimes they bite or something, and now you've got to deal with something like that. We find out that people are often in frequent conflict. If your job, the nature of it, that you're always in some conflict with someone, that is difficult, high stress. If you're required to make a lot of fast decisions, that's a high stress situation. And sometimes workplaces develop these subcultures, and we tend to think of it with executives, but I've studied low wage work extensively, and people report constantly that there's a highly competitive environment that gets set up. And many times they feel like, wow, I'm not paid well enough to be dealing with this competitive environment on the job. So a lot of times management is not setting up a team spirit or a good camaraderie, but rather a competitive situation. And people feel like the effort they're putting in that isn't matching the reward they get out, either monetarily or just the way they're treated. So there's a couple of different theories, and the effort reward imbalance theory is super important. It actually is known to cause long-term cardiovascular effects when you work in a condition where you don't feel that your effort that you're putting out is being rewarded, either acknowledged or with pay or acknowledged with some kind of recognition. Yeah.
So really what we're talking about here are vulnerable workers. And it's sometimes hard to realize just how many people are stuck in those low wage jobs, isn't it?
Yeah. I think
So,
yeah, our findings are, very off, depending on the city, depending on where we are, between 38 and 50% of the jobs are not making a living wage. So people are working two jobs to try to make ends meet. They're working jobs that pay around $15 an hour, maybe a little more now, but they're trying to raise families on this. They're not just making extra money while they get their education or making extra money in their retirement, even though they already have streams of income. These are their central, wages that their families depend on. And so when 38 to 45%, it's hard to tell, it depends how you measure. When that many people are facing those kind of economic precarity, that is its own public health problem. On top of the occupational exposures, it's not safe on the job, people don't get good training. If they do get good training, it's completely irrelevant to what they're doing. They get great training on stuff they never need to know, and then there's a chemical in front of them that they don't know how to use. So very often we see that disconnect, training that doesn't relate to the reality of their job. They're having to face difficult conditions, but then the low pay itself becomes a public health problem in that it's difficult to afford good nutritional food, hard to afford healthcare access, hard to afford transportation. And it's just, their lives end up being very chaotic because their schedules are changing a lot. There are many jobs they don't give a regular schedule. It's not a 9 to 5 thing. They're always shifting how many hours they're dealing with. They have to change up their childcare a lot more than the other types of work. So these low-wage jobs create their own firestorm of crises that people are just in a constant, putting out fires. And it makes it hard for them to remain stable in their employment as well.
right. And, talk about stress levels escalating through the roof. I want to make a point here. Everybody talks about, oh, gee, once we get to a $15 minimum wage, that's what people need to live. The truth is this. If you are lucky enough to have a 40-hour work week and you make $15, that means you make $600 a week. And then taxes come out and all those other kinds of expenses come out. And those are not living wage jobs. There's no way they are living wage jobs. And that's why so many low wage people end up on social supports networks and services that their counties may offer. So it's not that people aren't working and working hard. It's just they're not being compensated. So,
Agreed.
I think that's
Especially in
always,
those jobs, yeah, where you have, people doing super valuable work that we can't do without in our society. If they were to all stop. Now, we've noticed this in the pandemic. Essential workers, we suddenly called them essential workers. They were always this epidemic in plain sight, getting hurt, getting sick, dealing with all these tough conditions and low pay. And now we realize they are essential. And I hope that our pandemic will have taught us that. But many of these low-paying jobs are caregiving jobs. They're caring for the elderly. They're doing very basic, important functions that keep people alive, that keep our facilities everywhere we go clean. They're the people who cook the food, prepare food, serve us, take care of these retail operations. It's profound, the kinds of important work that's being done and the sort of lack of recognition of how much they're being underpaid. I worked specifically with home care workers, and that's where it's very often profound. I mean, how much it's an art to care for someone, to go into their home, into their space, and physically care for them while they're dying or while they're very ill or disabled. And do that well takes serious skills. And people get a 10-week training course and off they go. And I think that work is very difficult, very physically demanding, emotionally wrenching, very often dealing with grief. I talked to a young home health aide who was 30 years old, and she had 11 of her patients die in the previous year. These are people that they naturally bond with, they like doing this work, and then to be not compensated for by our systems, our medical systems, is a heartbreaking thing, and it affects their health long term, which is psychological health and their physical health. So these are important issues that we raise in the report that, the original report wasn't as focused on low-wage workers. And also, it's the first time, we're able to look at ethnicity and the differences between men and women for some of these variables that we looked at. We do see that the low-wage work, women are sorted into that work. So when you look at the occupations, they're very different. The occupations of low-wage work and the exposures is much different than better work, right? So that is very interesting when we look at, say, the top 5 jobs that are low wage. They're very different than the top 5 jobs and that women occupy versus men, and also that white people have versus Blacks, Latinos, and Asians. So that's what makes the study that we did, interesting to note who's doing what work in our society. And when it's disparate, when we have disparities, where differences, there are reasons for that are structurally based that we can begin to work on, because we can notice it and say, what kinds of unfairness are being put into this? How is it that, the top jobs for white folks pay a little better? They are maybe recreation, mechanics, repairs, gardeners, preschool teachers, but then the top jobs for minorities are laundry workers, maids, health aides, janitors, taxi drivers. It's different. It's different kind of work. It's more dangerous and more grilling on the body, the work that the minority folks are doing. So we're still sorting people into jobs in our society in unfair ways, and the opportunities that people have are not equal for healthy work.
I'm glad to hear you speak in particular about home care workers, because I did a show just a couple of weeks ago on that particular issue, and how how low wage that work really is, and yet how absolutely vital. And your point about the skill sets is very well made. Unfortunately, for a lot of people, the bottom line is the actual costs to society in terms of dollars about the folks in these jobs, and the medical costs to treat them. But the human costs really can't be measured as easily as the economic productivity, though, can they?
Yeah, I mean, people's pain, especially if you run into the patients that we see in these clinics, I mean, their lives really, it's more than meets the eye. Yes, they have physical conditions they have to deal with, but the physical and psychological pain is really hard on them, and it's not measured. But when we look at costs, it is important to consider what it's costing all of us. It's the cost to society we estimate quite a bit higher than the original report, even given, inflation and everything. We're estimating over $4 billion is spent. And this is on healthcare, direct healthcare, and that's the lion's share of it. But also considering lost productivity of people that are not working anymore, not working at the level that they used to be working, and the rippling effects that has on people's families. Furthermore, we think that employers, are only really responsible for maybe, what did we say, 18%, 71% of it is being borne by all of us in society. It ends up that's how it shakes down. And, that's a huge amount of money. And we're hoping that does get the attention of the state legislature and others in power, because the policies that we put in place really should not, the workers in New York State should not have to be bearing on their backs, their own problems that result from work. That's something that should be not shifted to them. But very often that's what ends up happening. The injured workers and their families end up having all those costs shifted right onto them. So we're, the awareness, so much prevention could actually be enacted, preventive, moves, a number of them, different collaborations, different types of education and prevention to prevent. All of this is preventable theoretically, because we shouldn't just be putting up with work conditions that put workers at this much risk. So we know how to fix many of these, almost all of them. There's a prevention angle that can actually make change. So when we think about the services that these clinics have available now, it's too scarce. We don't have nearly enough occupational medicine physicians. We don't have nearly enough preventive programs, in order to abate these hazards. And so it's, that's one of the main things we bring out in the report. There are only 30 board certified occupational medicine specialists that accept workers' compensation insurance in the entire state. A third of them already work for our network. So there's just so few doctors who know how to connect the dots between your work-related illness and how to get better, and what, make sure the causal connection is made and navigate through workers' compensation properly, and then, start building a new life. Those our services are important, high quality services. They're not quick. You have to take a long work history. You have to understand what all the exposures were. You have to connect, do a bunch of laboratory tests or whatever the doctor orders. It takes a while to work through all this and get our services fully going. And we want to do this work, and it's just completely too scarce for the big problem that we've uncovered in this report, that millions of people are exposed, and hundreds of thousands of people are getting sick from their jobs.
And the other thing, although in the interest of time, we can't take a deep dive into it, but your report makes some good, strong recommendations on how to treat and prevent occupational disease, as you just mentioned. So as we wrap up, Jeanette, what are your final thoughts that you'd like to share with our audience?
Well, I think we've said it quite a bit. We know we can prevent occupational disease from occurring. We have the expertise. We need to adequately fund the public health infrastructure that exists in the state. We need to build on the existing occupational safety and health infrastructure, and we need to integrate and collaborate across the state. There's not nearly enough of that. There are existing state agencies and existing community-based organizations and more that could be easily integrated and collaborate together. So that's a move we'd really like to see happen. And of course, one of the things we want to make sure we always do is that the people who are directly affected by their work conditions are the people we need to be talking to. It's a hallmark of all the work we do in the clinic. We actually talk to the workers in order to learn what their conditions are like, what is going on with them. And that, the capacity to have workers involved in all of our programming is very important. So we value that. And between all of those things, putting more resources toward it, creating policies that protect workers' health and championing them, making sure they go, like the New York HARO Act was a good one, where we have people able to have health and safety committees, especially to address COVID protocols in the workplace. Those kind of efforts can be expanded upon and leveraged to really make a difference in the health of working people in the state.
Jeanette, thank you so much, and thank you for the work you do for the clinic network, because explaining all this is very important, because it's how we educate not just the workers but also the decision makers who provide the funding and who can provide the structure and the framework for laws to make workplaces safer for folks. So I appreciate your time today, and I appreciate your work, and we'll look forward to seeing how some of this information is actually able to improve workplace for New York State workers. Thank you very much for coming in.
Thank you for having me.
Oh, my pleasure. So these conversations are a production of North Country Matters. This show is a civic collaboration between the League of Women Voters of St. Lawrence County and the Potsdam Public Library. Until next time, remember, our North Country matters.